Welcome to the Caregiving Podcast. I'm Inga.
And I'm Julie.
And long story short, we have Caregiving. We are two momtrepreneurs who have built an in-home care business from the ground up, guided every step of the way by God's care and fueled by agape love. Almost 14 years later, we felt called to create this podcast as a resource for families with caregiving needs. Whether you care for a family member or are looking for advice on professional caregiving, we want this to be a platform to support you.
Each week, we will come to you with encouraging stories of families who have found the right balance for their loved ones, tips for how to care for them and you, and much more. We hope you continue to join us each week as we share in this exciting new journey together.
Hello, Sunshines, and hello, Julie.
Well,
how are you?
Well, I'm kind of not settled in my seat yet, but I'm good. I'm great.
Perfect. Y'all situated.
Yes.
So winter. What's your favorite part?
Oh, when it's over.
Same.
I just, we need winter. I come from an egg background. I totally understand that we must have it. But when you work on a farm or a ranch, all it really means to me is a lot more work.
Yes.
And so it's perfectly selfish on my part because so many people, they love to get out there and do that. And I just don't like to be cold. So yeah, I love when spring comes around.
Same. I tolerate the winter because I don't like the bugs that go along with like warmer climates.
Yeah.
Although we were working in the basement the other day and the spider had to ruin it. It was going so well. And then out of nowhere, this gigantic spider dropped down from the ceiling. Kevin was on the ladder. I apparently overreacted.
Oh, I can't imagine that. And it was
spider.
This big, I'm sure.
Huge.
Yes.
Huge. It almost took my life.
Oh, boy, that was
scary. I don't like spiders. Anyway, so that's why winter for me.
Yes.
Because the bugs are smaller.
The bugs are smaller.
Cool. I think we should just go right into our verse of the week. And today we have for you 3 John 1:2. Beloved, I pray that all may go well with you and that you may be in good health as it goes well with your soul. Tell me why you picked this one, Julie.
I picked this one because it talks about health and well-being. Mm-hmm. And our speaker, who we haven't told you who it is yet, is all about that. And so I thought of her when I picked this verse, because her whole mission in life is to help us be as healthy as we can.
Oh, that is fantastic.
I am pretty sure every day she's like, help me help you. Listen to my words of wisdom.
Absolutely.
Yes.
Well, if our listeners out there, if you have a verse that you'd like to share with us, please email those to thecaregivingpodcast@gmail.com. We would love to hear from you. If it's something that has meaning, tell us your story that goes along with it. Or if it's just a verse that you love, just send it and we'll put our own interpretation on things. You want to start us out with your uplifting story, Julie?
Put on my spectacles.
So make a spectacle of yourself, Julie.
Always. So this is about a gal who said she was a nervous wreck as I waited for surgery on my ruptured disc. Although I endured intense pain in my leg for months, I'd put off going to the doctor. I was terrified he'd tell me I needed an operation. I can't believe you waited so long, he chided me as I finally went. Your leg is bothering you because a disc in your back is pressing on a nerve ending. We'll schedule surgery for next week. Even after I explained every detail of the procedure to my husband, Dave, and I was still a nervous wreck. I prayed for comfort all the way into the nurse operating room until the anesthesia took effect. When I came into the recovery room afterwards, I didn't know where I was or why a nurse hovered over me. My vision was so foggy I could barely make out Alice on the nurse's name tag, and her face was a blur. But her voice comforted me. Did everything go okay? I asked weakly. Alice took my hand, saying, your operation was successful. The ruptured disc has been removed. I spoke to your husband, and he will be up in a minute. She smiled as she stroked my hand, and I drifted off to sleep, soothed and relieved. When I awoke, Dave was sitting on the edge of my hospital bed. I was so glad to see him. After I repeated everything Alice had told me, I noticed his puzzled expression. Suddenly, it dawned on me that I had understood everything she'd said, down to the last detail. You see, I'm deaf. And although I lip read, with my vision blurred, there was no way I could have made out everything my nurse uttered. And yet I heard every word, getting just the comfort I needed.
Oh, that's a good one.
Yeah.
Oh, I love that.
Yes.
Well, my story is about Julia and Pretzel. So in 2004, Julia Dupree was diagnosed with type 1 diabetes. She was just 6 years old. So her body was unable to produce its own insulin and making it hard to control her blood sugar. And I think we all know that that can be fatal if it's not taken care of. So Julia went on in her life, and then when she became a young college student, she was actually put on a waiting list for a Diabetic Alert Dog. And after 2 years, she actually got her dog. Yep, she was able to adopt her new service dog through CARES. And we'll put some information in the show notes on how to go and look that up. But anyway, 14-month-old Pretzel was trained to alert Dupree when her blood sugar levels are dangerously low or high. They're trained by scent and are amazingly able to detect glucose levels by scents that come from the owner's breath and palms. So when Pretzel smells a sweet or fruity scent, it means that Dupree's levels are high. And when he smells a sweaty scent, it means that they are low.
Oh, my word.
When either of these happen, Pretzel will either stare at Dupree or bark at her to alert her. And before having Pretzel, Dupree kept track of her levels with a device in her leg called a Dexcom. Unfortunately, the device wasn't always very accurate, so that caused a lot of anxiety for her. But now that she has Pretzel, she says she has a new sense of freedom, and she's able to move into a college dorm room and not have to worry about fainting or sleeping through an alert. So not only is Pretzel a lifeline for Dupree, but she also is her best friend. She sleeps with Dupree every night and always keeps her company.
Oh, my word.
Amazing.
That's
Animals
awesome.
are amazing.
Animals are awesome.
Yeah.
Yes.
Okay, well, we've given you a little taste, a little teaser on what we're talking about.
Who could it be?
So we would like to introduce to you Cody Sue Bartholemew. Cody Sue comes to us, and she is a nurse extraordinaire, and she has tremendous training and personal experience with diabetes. And so I'd like to turn it over to you, Cody. Give us a little bio. Tell us about you.
Thanks, Inga and Julie. So yes, my name's Cody Bartholomew, and I am a nurse. I have been a nurse for 14 years this year, and I, as nurses can do, have done a lot of different things as a nurse. I've been an acute care nurse. I've worked in an ambulatory setting. I have been a nursing leader. But one of my favorite nursing things that I've done and continue to do no matter what my job role is be a diabetes educator. And the reason I like that so much is because I, too, have type 1 diabetes, and I have been diabetic since I was 7 years old. But I love connecting with people and teaching them about diabetes and just helping them navigate the challenges.
Mm-hmm. Well, and you've been here before. You did a training for us, for our caregivers, and I was really impressed with it because you do bring that personal experience to it, and you're very practical, and you have like the real human touch to it versus just what you read or learn in a book. And that's something, one of the many reasons why we wanted to ask you on to our podcast today to talk to us about that. So tell us a little bit, there are different types of diabetes, type 1, type 2. Can you walk us through what those are?
Yeah. So I won't go in numerical order. I'm going to start with type 2 because that is the type of diabetes that most people have and what most people think about when they think about diabetes. Type 2 diabetes is a metabolic condition, and the definition of type 2 diabetes is that your body just doesn't make enough insulin or isn't able to use the insulin that it does make efficiently enough to keep your blood sugars in normal range. It's often associated with obesity or older age, and it just because the bigger we are, the more places basically the insulin has to go to take care of us, and sometimes our bodies just cannot get the insulin to all the places that it needs to go. Type 2 diabetes can be managed with diet and exercise, usually at least initially, not always. Oftentimes it does require pharmaceutical intervention, so oral medications and oftentimes insulin at some point as well. But most of the funny memes you see about diabetes or, like if you eat all that sugar, you're going to get diabetes, all of that stuff, that's usually associated with type 2 diabetes, which is not true. You're not going to get diabetes from eating too much sugar, by the way. Type 1 diabetes is actually an autoimmune condition. So type 1 diabetes is caused when your body basically attacks itself and your pancreas stops producing insulin. So Insulin is made in the beta cells in the islets of Langerhans in your pancreas, if you want some big vocabulary words for today. And they don't know all of the causes. They think it's usually triggered by some viral illness. Wow. And that viral illness kills those beta cells, and it quits producing insulin. So
wow,
who cares if you quit producing insulin? What happens? Well, insulin, I tell people, is like a key. And it's the key that lets all of the energy we get from the food we eat into our cells so we can use it. If you don't have any insulin, you could eat the best, most nutritious food in all the world, and you'll starve to death because it can never get into your cells. Insulin is what is able to get it in there. If we don't have insulin and it can't get in our cells, all the glucose that is from our food just hangs out in our bloodstream because it can't get to where we need it for energy, and it raises our blood sugar. So, again, type 1 is caused by some autoimmune condition. Lots of times people with type 1 diabetes have additional autoimmune conditions as well.
Wow, I did not know it was autoimmune.
Yeah.
And can that happen at any age?
Yes. And so type 1 diabetes sometimes is called juvenile diabetes because often it presents during childhood, but it can occur at any age. I've had many patients that were diagnosed in their 50s or even later, 40s, 30s. I mean, at any age with type 1 diabetes. Sometimes, unfortunately, because we just always attribute type 2 diabetes to adulthood and type 1 diabetes to adolescence, people are misdiagnosed initially with type 2 diabetes if they develop it in adulthood.
Wow. So how is it determined whether it's type 1 or type 2?
So the need for insulin. So if you were initially diagnosed with type 2 diabetes, they'll probably put you on some oral medications. And if that's not able to control your blood sugar, oftentimes if you have to resort right to insulin, there's also lab tests that they can do to look for certain antibodies that are produced when you have type 1 diabetes. But usually it's kind of how it's treated. And like look at the onset and blood sugar levels. If your blood sugars are really, really high when you're diagnosed and, basic interventions are not lowering them at all, it's because you don't have any insulin there.
Wow. Talk to us about signs and symptoms.
Yeah. So signs and symptoms of type 1 and type 2 diabetes are the same because they're all caused by elevated blood sugars. They're usually more extreme in type 1 diabetes, and usually the onset is faster. So some of the classic symptoms that you'll hear about is increased thirst and hunger. And that's the hunger is because, like I said, if you don't have enough insulin, you're literally starving to death. So kids or adults that are diagnosed with type 1 diabetes are just famished. Like, it doesn't matter how much they eat, they just are always feeling hungry because their body's not able to get that energy that we're craving when we want food. And because you have all this extra glucose in your bloodstream, your body is trying to get rid of it the best that it can. There's really very little things that our bodies can do to get rid of glucose besides insulin. But our kidneys start processing it and we pee it out. So a little bit of glucose you can lose in your urine. So people have to pee all the time when they have diabetes. And then they become dehydrated and they have like this unquenchable thirst. So frequent urination and increased hunger and thirst. Also lethargy. So they're super tired because they don't have any energy in their body. And so they're like sleepy. Kids might be sleeping on a desk, just don't feel like getting up, just really don't feel good. Wounds that won't heal sometimes kind of are a sign of diabetes, and that's usually in type 2 because type 1 is such a fast onset that you're not usually going to get like poor wound healing.
Right. It
could occur, but the reason is, again, because your body doesn't have the energy that it needs to help heal those wounds, and also you have all this additional glucose in your bloodstream, so infections or wounds are just thriving off of that additional glucose that you have in your bloodstream, and so it just kind of festers those wounds and they're not able to heal.
Wow.
So is that where you've seen, I've heard of people losing their toes or their
So
limbs.
that's caught so people losing their toes or limbs related to diabetes is usually a complication of high blood sugar over a long period of time. And so when we have all this extra glucose in our blood over a long period of time, it hurts our vascular system. So all of our teeny tiny blood vessels, they're kind of eroded. I explain it to people like it's like the salt on the roads when winter does come and we have to salt the roads, that eats the bottom of our cars, and all of our stuff. It's the extra sugar in your blood is kind of like that to your vascular system. And so a lot of complications, long-term complications of diabetes are all because of that. So people lose vision because we have teeny tiny vasculature in our eyeballs, and they lose circulation and blood flow to their extremities because those are teeny tiny blood vessels. It affects the blood vessels in our kidneys and our heart. So a lot of those complications of diabetes, almost all the complications of diabetes are related to our vasculature system and damage to it.
Talk about neuropathy.
Yeah, and it's caused by the same thing. So if we're not getting adequate blood supply to our extremities, it starts to damage those vessels. And so we can't feel our fingers or our toes because we don't have adequate blood supply.
Wow. So if somebody thinks they've got diabetes, if somebody's like, oh, I've just been feeling so thirsty, or I've been getting dizzy. When I eat sugar, I get a rush or whatever. How do you go get checked? Who should you talk to?
Always your primary care provider. So we all should have a primary care provider. Here's my nurse plug. And we all should be seen by them at least once a year if we don't have any health conditions. And we all should have yearly labs. So if we had something like that came on suddenly, definitely go see our primary care provider. If you don't have one, you should get one, but you could go to like a walk-in clinic or something and let them know what your symptoms are. But they should always do yearly labs. One lab that we check a lot for patients with diabetes is a hemoglobin A1C, and that measures your blood sugar over about a 3-month time period. And the reason we can do that is because our red blood cells live for about 3 months. So you can look at your red blood cells and see an average of how many glucose molecules are connected to all those red blood cells, and you can get an average blood sugar over a 3-month period. But that's a lab that even if you don't have diabetes, as we get into adulthood, or if we have other risk factors, that should be checked yearly. Like if we can see that it's becoming a little higher, then we can, intervene faster to prevent, maybe the onset of type 2 diabetes. But what they would do is, if you came in with those symptoms, they would just do a basic blood glucose check to see where you're at. And then do a hemoglobin A1C. If your blood sugar is a little elevated, but your A1C is fine, you're in a normal range, maybe it's something else. But if your A1C is elevated, that means this has probably been going on for some time.
So when you talk about over a 3-month period, is it just one test that is able to read
it gives you an average blood sugar over about 3 months.
Okay.
And it's kind of like it's maybe not the best indicator of actual blood sugar control because it's just an average. So think of math, an average, like my average might be real good, but I have like some really, really high blood sugars and some really, really low blood sugars. It's kind of the gold standard. But actually what we should watch with people with diabetes is time and range. Like how often are you actually in that normal range for blood sugars? But an A1C is just an easy check. Sure. And it is something that, insurance companies want to know what your A1C is. It's a risk evaluator. For
I've always heard of that, but I really never understood what it was.
Well, now you know.
Yes, I do. Thank you.
How often do you see situations where maybe a child ends up in the emergency room and it's like, way beyond either super, super high, super low, and they don't know?
Yeah, so if their blood sugar is really low, the only way your blood sugar can get super low is if you have insulin. So somebody should not have, I guess I should say, if you have diabetes and your blood sugar is super low, it's probably related to insulin. Are there other conditions that could cause hypoglycemia? Yes, but they're not very common.
Sure, okay.
But most kids are diagnosed, like it's an ER visit or a doctor visit, and often require hospitalization.
Right.
So what happens is when your blood sugar gets really low and you don't have any energy to feed your body starts breaking down protein to fuel itself, and that causes our body to produce acid, breaking down that protein, and it leads to what's called diabetic ketoacidosis. And then it throws off our whole metabolic system and can cause brain damage or death if not addressed.
Wow. So in a perfect world, what is just one of the most simplest things that you'd like everybody to know that you could just, if you had a nugget of information to share?
One of the biggest things to know about diabetes is once you're diagnosed, it is a lifelong condition.
It is.
It never goes away. You can't cure it. And basically it's just like a crazy math game that you never get the right answer to. It's not as easy as just not eating a cookie and going for a walk. And I think, the misconception is that people, first of all, that do it to themselves, like it's their fault that they have diabetes. And if they would just not eat cookies and walk more, then they would be fine. And that's not the truth.
Right.
It's a very, very complex disease to manage, and you don't get a day off or an hour.
Are we seeing more and more of it, or
yes,
what's the trend?
So type 2 diabetes, there's an increase nationally in type 2 diabetes. Really in the U.S., they attribute it kind of to our lifestyle. So it is associated with diabetes and other metabolic things. And we just, as citizens in the U.S., eat a lot of things that maybe aren't the best for us. And not that you can't eat those things. It's just everything in moderation, right? And we're kind of inactive as a culture. And we like to sit on our phones and look at Facebook. And our kids play video games. And we just don't get out and move. In other countries where some of those things aren't as common, they have lower incidence. There is also an increased incidence in type 1 diabetes, and I haven't seen any recent literature to explain why. We know that the incidence is going up with kids developing type 1 diabetes.
But we don't know why.
Yeah.
Is it hereditary?
Yes. So type 2 diabetes does have some genetic tendencies, and type 1 diabetes does too. The hereditary components aren't as strongly connected in type 1 diabetes, but there's definitely some connectivity. And there are lots of studies out there. There's this cool study called TrialNet that patients who have, so if you have a first degree family member with type 1 diabetes, you can be screened. And what they're looking for is development of those antibodies that I talked about that they can, to identify type 1 diabetes. Like those can be identified early, and sometimes they can, they have trial interventions that they can do. Like if you show that you are at a higher risk for developing it, then they can institute interventions to help prevent that or slow down the onset.
Wow. So we obviously deal with the elderly. So please talk to us about how we can make sure that we're helping them, and then what things happen to make it harder even as we age to make sure we're giving ourselves the right dosage, all of that.
Yeah. So I would say one of the biggest things is just always making sure that the people that are around your patients with diabetes know that they have diabetes. So when our blood sugar's high, we're lethargic and, we don't have enough energy and it hurts our vasculature system. But when our blood sugar's low, when we have too much insulin or had too much medication or didn't eat enough food, that is an immediate, it can be an emergency. So our brains have to have glucose to function. Our brains don't function without glucose. And if you don't have enough glucose or sugar, you can die fairly quickly. So it's really, really, really important that people know that somebody has diabetes and they know the signs and symptoms of hypoglycemia. And because glucose affects our brain, all of the symptoms of low blood sugar or hypoglycemia are all kind of related to our brain. So our reaction times slow down. Sometimes we slur our words. Maybe our coordination is impaired. Maybe we're really irritable or emotional. But those things can happen for a lot of reasons, right? And especially in the elderly, their cognition might be impaired because they have some other comorbidity or condition, and their mobility might be limited for some other reason. But it's really important to, if we know these patients and we spend a lot of time with them, if there's a change that you can notice, even if it's subtle, to at least check to make sure that their blood sugars aren't low. I always tell people, so people get afraid, what if their blood sugar is not low and I gave them sugar and now it's high? Well, high blood sugar over a long period of time is dangerous, but low blood sugar is more dangerous in the immediate. You're not going to kill somebody by giving them some sugar or intervening if you think their blood sugar is low, if it's not. But if you don't intervene, something really bad could happen.
Oh, yeah. One time I called my dad, and Mother had gone to see my sister for the weekend. And I called Dad, and I was just yakking at him. And all of a sudden I was like, wait a minute. Hey, talk to me. Are you okay?
Mm-hmm.
And he was very lethargic, very slow. It took him a long time to get, and it ended up being more of the hypoglycemia. And thankfully, my Aunt Carol was able to go over there and do everything she needed to do. But boy, it acted almost like a stroke.
Exactly. And sometimes, so I will like, any EMS personnel is very well versed in this. And if they show up and suspect somebody's having a stroke, they always check their blood sugar first because the symptoms are very, very similar. I've had some episodes in my life where my whole left side has gone numb.
Oh, wow.
So like flaccid, can't move my left side because my blood sugar was dangerously low. But if that was an adult, like they would have totally thought I had a stroke. Like, you know, droopy face, all of the things that we think about that are and it because a stroke affects our brain,
right?
And so does low blood sugar.
So that's vascular.
Yep.
Huh.
Are you the one that was talking about the gummy bears? No.
Well,
having gummy bears, like if someone has diabetes, just having them like close by in case of the low blood sugar.
Yeah, and I guess I would say that. So you know, for your caregivers, always know where there's something that they can help treat that low blood sugar. If people are having significant low blood sugar and they're cognitively impaired, sometimes it's hard for them to swallow.
I was wondering
So
about that.
I like fruity candy. I always carry it because it's something that doesn't like melt or really like, you know, you can eat a gummy bear that's a little bit old. It's kind of more chewy, but it still gives you the intended effect.
You can get it done.
Yeah. But if it's like a chocolate bar or like carrying cans of juice around, I've done that and like accidentally stabbed them with a pencil and they've exploded in my purse, you know, like all of those things. So I prefer like fruity candy, gummy bears, fruit snacks. Those are kind of my low blood sugar food that I can eat. If they get cold, you can eat them. If they get hot, you can eat them.
See?
All the things. But if you can't swallow well, you can choke.
Right.
If you try to eat a gummy bear.
Right.
So what you should always have available is some rapid form of sugar. So honey is really good.
Oh.
Frosting in a tube is really good. Something that they're not likely to aspirate on.
Right.
But you can get them sugar really quick. There's also emergency like injectables to treat low blood sugar. So glucagon, and anybody that has diabetes and takes insulin really should have glucagon available. The thing about glucagon as a treatment is you're never probably going to give it to yourself. Like you're going to need help because if you're in that place that you can't eat something,
someone's going to be giving it to you.
Yes. But have the people that are around you know how to use it. Right. Not too far back, I was trying to remember if I had a current prescription for like glucagon also expires. I will tell you, if you find expired glucagon, it's still going to help. It might not help with the same effect, but you could still use it. Anyways, I asked my husband, I said, where's my glucagon? Like, is it current? He's like, you don't need to know where it's at. I was like, okay. Yeah, I guess you're right because like I'm never going to give it to myself, but I do go to the pharmacy. He was like, it doesn't matter where it is, Cody. You don't need to know. And I was like,
as long as I know.
Yep, he knows. He knew. I think he was afraid I was going to move it somewhere and put it safe, you know? Like,
And so that everyone would remember and then you can never find it again. Done that.
So anyways, having those things around are really important. But if you have diabetes, and especially if you take insulin, because that's what's going to dangerously lower our blood sugar, you should always have some rapid source of carbohydrates around. And really, it can be any carbohydrates. You could eat a sleeve of saltine crackers. A sleeve is way too many to fix your blood sugar. But when it's really low, you get like this panic feeling and you probably will eat a sleeve.
Right.
It can be any source of carbs. It doesn't actually have to be sugar. So anything that has carbohydrates. If you add fat or protein to the carbohydrates, it's just going to take longer for that sugar to process. And so you'll feel low longer, but it'll still fix you in the end.
Wow.
So what is it with, is everybody different? But some people, you know, she has to check her levels 3 times a day. She has to give herself injections twice a day. What's standard now?
Yeah, really, it is very, very individualized, and it depends on treatment plan. So when I was first diagnosed in 1991, there was limited treatment options for type 1 diabetes, like only, you know, regular and NPH insulin. I took pork insulin, so insulin that came from pigs when I was a kid. We've technology has improved a tremendous amount. I no longer have to take animal-derived medications, but there's so many unique treatment options that really it depends on each patient. And maybe they just take oral medications, and maybe their A1C is decent, so they just want to check once a day. And it's totally up to patients and their providers. I would say one thing to kind of highlight, if somebody has diabetes, they really need to have frequent interactions with a provider because it changes. So you might have a regimen that works perfect, or an insulin dose that works perfect, or whatever you're doing that works perfect, and it lasts for a long time, and then all of a sudden it's not working anymore. That's totally normal. It's really irritating.
So you just can't assume that.
It's just ever evolving.
Right. Like, I mean, and I think that's the other misconception, right? Like, Grandpa's been doing so good with his diabetes for 10 years, but all of a sudden he must be like sneaking cookies because his blood sugar's high all the time. Maybe he is, but maybe not. Maybe he just needs his treatment adjusted. And that's why it's so important that people are always seeing a provider, or a diabetes educator, going over some of those things. If you haven't made any changes to your eating habits or your exercise habits or what you're doing, and your blood sugars aren't in range, then maybe you need more medication, or maybe you're going low all the time. Like, maybe you're doing the exact same thing, but suddenly you're having all these low blood sugars. Those are dangerous. Like, maybe we need to change your treatment plan. Sometimes medications don't work for people after a certain amount of time.
Interesting. I think one of the things that we actually see when we're doing home visits and such, and getting to people's houses, is the word very often is non-compliance.
Yeah, I don't like that word.
Yeah.
Yeah. And maybe they aren't compliant with what has been told to them, but maybe it's because they're poorly educated, or it's just really hard and they need more help.
Right.
Maybe math isn't their strong suit and we're asking them to do calculations.
Inga, you going to help me?
Or maybe
Yes, I will help you.
Or maybe they have some dexterity issues and they can't draw up something or change their Lancet, or maybe we haven't given them like a good type of lancing device, so it hurts like heck every time they test their blood sugar and they don't want to.
See?
Or maybe
I would be non-compliant then if it hurts every single time.
And I think that's why it's really important for patients to have good relationships with their providers. Yep. And I don't like when providers say non-compliant either, because and some people just are. Like, it doesn't matter what is wrong with what kind of condition we have. Some people just don't follow their treatment plans. Right. But I think usually when you spend time with those people and ask why, you can learn a lot of things and help them make better choices. And like, if they're non-compliant because they always just eat way too many carbs, like, maybe we just need to adjust their medication so their medication covers their carbs. Right. Their blood sugar's fine. Like,
right.
So
I like that. It's basically looking at the person as an individual and trying to figure out, what's working for them, what's not working for them, and what are the reasons why maybe they're not following that treatment plan. Yep. I always think about going back to like an Alzheimer's or dementia situation where there was a lady who she had this one sweater that's all she ever wanted to wear, and it drove the family crazy. Mm-hmm. But why? Yeah. Why? Yeah. She's fine. Anyway, there might be reasons that we don't.
Yeah, like why if they only want to eat a certain food.
Right.
So see, I think that's my aha.
Let's work with that.
Yep, that's my aha moment for this meeting that we're having, is that if somebody is cranky at Grandpa because he's eating cookies and he's in non-compliance, maybe that's a really great time for us to come in and say, hey, when's the last time you talked to the doctor or looked at that, and are we where we need to be with all of those medications?
And finding the right provider. Motivational interviewing is what comes to my mind, and that's something that I have done a lot as a diabetes educator. It's not just sitting down and like giving them a book and being like, these are all the things you need to know about diabetes to take good care of yourself. Yep. Like, talk to them about what's important to them. What are their favorite things to do? Like, what are the things that are really hard about this treatment program that they've given us? Maybe it's cost. Diabetes is such an expensive disease. Like, the out-of-pocket costs for people, like, maybe they're not compliant because they can't, if they buy their insulin this month, they can't buy their grandkids Christmas presents. And for them, it's not worth it. Like, there are so many things that I've learned in the years talking to people, and cost is often an incredible barrier. There's all this great technology that we can use to manage diabetes and really great new medications, but they're all expensive, and especially for people on a fixed income.
And that's really, really sad.
It is.
that people have to go without or make a choice to go without.
Yeah.
I mean, I remember one or the other.
Being a young, single mom with type 1 diabetes and like thinking of all the money I would have to spend just to literally buy my insulin, and thinking about all my friends with like nicer cars. And I would think like, I could have a way bigger car payment if I just didn't have to buy this insulin. Like, I mean, like that sounds kind of self-centered, but like that, like those are the things that our patients are going through for the rest of their lives. Like, it's not just like when I was 20, that was a sacrifice I made. It's literally for the rest of my life.
What advice would you give to parents that have younger children with diabetes based on your experience?
I like involve them in their treatment, and it's kind of the same thing. It doesn't matter our age. Like what are the things that are important to us? What do those kids hate about having diabetes, and what can we do to help that? Maybe we can't fix it. Maybe they hate their shots. Well, we have to give them insulin somehow. Maybe they hate their insulin pump. Is there a different pump that they would like more? Maybe they hate the low blood sugar food that you always give them because they don't like gummy bears. Like maybe you pick a different snack to pack them. I mean, like let them be kids and let them do the things that kids are going to do. I think, our understanding of diabetes is so much more improved than when I was a kid. And when I was a kid, I remember classroom parties, and everybody would bring cupcakes or cookies, and everyone knew I had diabetes. And I would usually get apples or Ritz crackers or something else. And I felt isolated and like the weird kid and whatever. What I know now is there's the same amount of carbs in an apple and a bunch of Ritz crackers as there was in a cupcake. And I miss a lot of cupcakes. And it made me really upset when I was a kid. And so I would say, let your kid eat the cupcake and give them insulin and teach them, like, this is what we need to do to manage our diabetes well. Should any of our kids eat cupcakes every day? No, probably not. Right. But let them be kids. And if they're going to go to a pizza party, like pizza's a real hard food for diabetes, like to calculate the right doses for, like figure out whatever works for your kid. And if it's a 13-year-old boy and he's going to eat a whole pizza, just figure out how to let him eat a whole pizza. Or he's just going to have a blood sugar of 400 later or not tell you that he ate the pizza. Right. I have like one kiddo that I, worked with for a lot of years, loved Mountain Dew. Like, again, should any of our kids have Mountain Dew? Oh, probably not. Right. But, like he loved Mountain Dew, and he would hide Mountain Dew. He'd get it and he'd hide it and he'd drink it, and his blood sugar would be really, really high. And his parents like couldn't figure out. He'd come home and he'd like get it out of the soda machine at school or whatever. Right. And before his parents got home, he'd drink all the Mountain Dew. Like talk to them and figure why always on Tuesdays is your blood sugar 400 at dinner? Well, it's because I drink Mountain Dew. Right. But when it's the when you can't and everyone else does, that it makes it really, really hard. And I mean, honestly, even as an adult, I work with a bunch of nurses, and I can't tell you how many times they're like, "Oh yeah, sorry, we brought cookies. I know you can't have them." Like
I will have the cookie.
The only cookie I can't have is one with poison in it. Right. Like I'll eat a cookie if I want to. And sometimes is there times that I choose not to eat a cookie because maybe my blood sugar is high and I'm trying to figure out why, and there's things going on. Yes, but I'm an adult, and I will make those decisions. Thank you. I don't want you to make them for me. Yeah.
So I love that so much.
It's so awesome.
Just talking to the people. And like you said, it doesn't matter what the age is, but just having the conversations and trying to work around it so that people don't feel like they're being deprived of something or not allowed to participate in something. And
like for changed.
Yeah. And for kids too, like being embarrassed about it, like, and like, because we have these social stigmas, like you did something if you got diabetes and it's like somehow bad or whatever, like kids should like let everyone know that they have diabetes. That's what, to keep them safe because of all the things that can happen, especially when our blood sugar is low. Everyone you're around on a regular basis should always know you have diabetes. Like I tell all the people I work with, like, if you see me sleeping on the desk, please give me sugar. If I bite your head off and you think, wow, that was totally unnecessary, ask me if I need something to eat. I might bite your head off again and tell you no, but I'll probably go in my office and eat some crackers and then apologize later. It's really, really, really important. And especially for like teens and preteens, like so many dangerous things can happen if somebody doesn't know to intervene. And if they feel accepted and their peers know about it, they will look out for them.
Oh, absolutely.
And they'll feel more included. And if they can hang out with them and eat the pizza and they just have to take some insulin, then everyone's going to be better off.
Yes.
And it teaches the other kids, like, to, you know, about other health conditions. And maybe those kids can teach them, and, you know, they don't post the same silly memes about diabetes.
Yeah. That are wrong.
Correct. Yeah.
Oh,
man.
wow. Wow. So a lot has changed from when you were a kiddo until now. You just actually showed us on your phone how you could check your blood pressure, your blood sugar.
Yeah. So I also, like, for the YouTubers, here's my continuous glucose monitor here on my phone. And I think that's probably one of the best things in the last 30 years of having diabetes is just the technology.
Wow.
And when I was a kid, I took multiple injections every day, and I had a really regimented food program, and I had to check my blood sugar all the time. And really, when you check your blood sugar, that's just a moment in time. Mm-hmm. So if my blood sugar is great right now, it's 100. That's what we always see in the commercials, right? When they show all the diabetes things, I've never seen a commercial that doesn't have anything but an in-range blood sugar.
Right.
So there you go. That's a misconception. Like, people that have type 1 diabetes and wear the Dexcoms, like in your thing, like, their blood sugars are not always in range.
Right.
It doesn't happen.
Right.
Oh.
But when I was a kid, so it's a moment in time. So if you check your blood sugar and it's 100, that's perfect blood sugar, and you might just go on with your day. Well, maybe it's 100, but it's like rapidly going up because you just ate lunch and you didn't cover with enough insulin. Or maybe it's 100 and rapidly going down, and your blood sugar is going to be low soon, and you're going to need an intervention for that. So continuous glucose monitors check your blood sugar every 5 minutes, and it's sent to some sort of device. So you can really manage your blood sugars and kind of, like, you know, see trends. What happens when I eat this food? Does it, like, do I actually need more insulin than I think I do? Do I need less? Do I know that 2 hours later after I do this, that I'm always low or I'm always high? When we're just checking our blood sugar at set times a day, or when we don't feel good, like, we always tell patients, you know, who don't have the continuous glucose technology, like, if you feel like your blood sugar is high or low, check it. But again, like, so they check and it's 300. Is it 300, but now it's starting to go down and you've just taken insulin to correct it? Or is it 300 and still going up, so you need more? Like, or maybe it's just 300 and staying there. The technology is amazing, and the things that you can do with it.
Wow.
Also, insulin pumps, that's another piece of technology that I have. And they just kind of let us micro manage our insulin doses. Especially for kiddos or somebody who's insulin sensitive, like a unit of insulin, which is how we measure insulin in syringes, that actually, I mean, so for me personally, at this point in my life, it changes. But for me, 1 unit of insulin lowers my blood sugar 70 points.
Oh, wow.
My goodness.
So that's a lot.
Yeah.
That's a lot of food. And if my blood sugar is 100 and I took 1 unit of insulin, well, that's, like, really significantly low. For somebody else, 1 unit of insulin might only lower their blood sugar 20 milligrams per deciliter. So, like, just having that, being able to change it and control it, certain times of day, like, carbs affect me a little bit different. So pumps, they're little mini computers. You still have to control them and tell them what to do, but they just allow you to just much more tightly manage your diabetes, and more conveniently too. So I'm not always having to get out a syringe or a pen and poke myself. I just poke some buttons.
And then it does it for you.
It does it for me.
So on the monitor, like that continuous, does it send you an alert or some?
Yes, and that's the other great thing about diabetes technology. So you can set your alerts to tell you when you're too high or too low, and you get to pick the ranges, so it's up to you. If it's low, or you can have any alert also sent to other people. So for parents, really great. They can see their kids' blood sugar all the time, and, you know, if they have to intervene immediately, they can. Really great. Or for your other loved one. So I don't alert my husband whenever my blood sugar's high or a little bit low, but if my blood sugar's less than 55, which is pretty low, my husband's phone beeps. And so usually he just texts me and I send him a picture of gummy bears, and then he knows I'm okay. We go back and look at my messages with my husband, like every couple days there's a picture of some fruit candy wrapper. But what if I'm sleeping and I don't wake up? Or what if I'm at work and I'm sleeping on my desk and nobody knows I'm there? And whatever it is. It's really, really great to have somebody that can help intervene.
Sure.
And for parents, I think that's really, really huge. But what if it's our elderly parents and their blood sugar is really low? Like if somebody can get an alert to go help them and give them
That's amazing.
something it's really important, or really high. I mean, it could be the same thing. So you can really kind of set the alerts up to personalize whatever is best for you.
Wow, there is so much information that we could just talk all day long.
Yes,
This is just amazing. Yeah. Is there anything that you wanted to share that is top of mind, or?
No, I know we talked about this a little, but like the holidays. So as a kid, again, because I never got cupcakes in class, the holiday parties always kind of sucked too, because we'd like decorate sugar cookies and everyone ate theirs and I took mine home and ate them on the bus when nobody was looking. But just let people participate. Like, this is something they have to deal with every single day of their life. So if you're at your Christmas dinner with your parent or your grandparent or your cousin or your whoever who has diabetes, like, don't be the diabetes police.
Right.
Help them if they need it, if they ask for help, if they're struggling, if they ask you to be an accountability person, be their person. But don't try to micromanage the things that bring them joy. That I think that would be my biggest thing to say, especially around the holidays, because it just seems like it's about food and being around people and, beverages and all those other things. I think another tidbit I could add is, alcohol also affects our blood sugar. And so that's another thing to be careful about, for the holiday parties, and why it's important for people to know you have diabetes. Having low blood sugar mimics the same things as being intoxicated. And so did your uncle drink too much?
Or does he just need a gummy bear?
Or is his blood sugar low? And so just having people around you that can kind of help navigate that with you is really, really important, especially around the holidays when we're all enjoying all the festivities.
Wow. So much information. That was huge.
Yeah, and
that was so
you
great.
spent like a couple hours with us a couple years ago, and every time I talk to you, I just learn so much more.
Yeah.
I appreciate it.
You're welcome. Of course. I love talking about it and teaching people
you
things.
are definitely an educator. So do you work with people that are like what is the age range of people that you work with?
So I currently am not working actually as a diabetes educator in my job, but because it affects people of all ages, I have worked with, I think my youngest patient that I can remember like working with was a little over a year when he was diagnosed, and working with that family, but patients well into their 90s that are alive and well with diabetes. So it doesn't matter your age, everybody, men, women, children, all ethnicities. It doesn't matter who you are or where you're from. Diabetes can affect you.
Yep. Wow. It's just cool to hear from you that it is, for the most part, pretty manageable. Yeah,
it is. And it's a lifelong condition, and you have to be on top of it, and it's frustrating, but it's, especially now, we have so many options. It's definitely something that it just makes you stronger and gives you a different perspective.
Yep. I love it. So do you have, can you talk to us about like prevention things that people can do?
Yeah. So the only type of diabetes that we can prevent is type 2 diabetes. And like I said before, because it's a metabolic condition, living a healthy lifestyle can really help reduce the risk factors of developing type 2 diabetes. So that's, trying to follow a healthy diet and exercise. Just being active and getting moving, like that helps our metabolism. We all know that. So that's really the biggest prevention strategy. Honestly, I tell people this all the time. Like, the things that we teach people how to manage their diabetes, doesn't matter what kind it is. Like, it's really about food and activity and lifestyle. Though it's things that all of us would be healthier if we followed, right? Like, even if we don't have diabetes, all the things that I talk to patients about managing their diabetes, we'd all be better off if we were able to follow it. But it's, it's not easy. Like,
right.
It's just not easy. So yeah, that's just the biggest prevention strategy. And if you you have a predisposition, like if it's in your family or at a higher risk, then maybe you have to try a little bit harder to prevent that. So just being aware of your risk factors. If I didn't really talk about this, with gestational diabetes is another type of diabetes that develops in pregnancy. If you develop gestational diabetes during a pregnancy, you're much higher risk of developing type 2 diabetes later in life. So just knowing that and working to prevent that.
Wow.
Yeah.
Oh, super information. Well, I think it's time to wrap it up, and you have a pretty good grandma saying.
I do have a grandma saying. So this is from Grandma Ruth, my husband's grandmother, and she always says, "The good Lord willing and the creek don't rise."
I love it.
Yes,
good job, Grandma Ruth.
So good. That's awesome.
Yeah.
Well, thank you, Cody. Thank you so much for being here with us. We always learn so much and just enjoy your company.
Thank you.
We're going to go ahead and sign off. But if you are out there listening, please make sure that you subscribe. You can do that on Spotify, on Google Podcasts, Apple Podcasts. You can go and watch all of this on YouTube. Please leave us a review, share us with a friend. You can join our Apaga Care and Share Facebook group. And send us your verses, send us your uplifting stories. Those can be sent to the caregivenpodcast@gmail.com. And I think that's going to wrap it up for the day. So peace out, Girl Scouts.
Yep. Have a super day.